Alhamdulillahi Rabbil Alameen wassalatu wassalamu ala rahmatan lil alameen. Assalamu alaikum. As discussed earlier, hemolytic anemia is suspected in a patient with decreased hemoglobin, normal MCV, and particularly with jaundice and positive family history. However, in the current scenario, family history is negative and there is no jaundice at presentation. So what are the other important investigations to consider? First, CBC. Complete blood cell count. Is it only anemia? Are only RBCs affected or other blood cells are also decreased too? Peripheral blood smear. What is the size and shape of the RBCs? What is the abnormal size? Is it a spherocyte? Are there any bite cells or schistocytes? Then a very important investigation is reticulocyte count. If it's very low, it means the bone marrow is not producing sufficient amount of RBCs. And if the reticulocyte count is high, so it means the bone marrow is producing more and more RBCs to compensate the hemolysis. Coombs test is usually done to detect any antibodies against RBC. Now the first option, aplastic anemia, usually it's a bone marrow disorder. The reticulocyte count is decreased, not increased, as opposed to the findings in this case. Second, spherocytosis. There is anemia, splenomegaly, a positive family history, and jaundice. Third, G6PD. It should be excluded because G6PD levels are normal, as mentioned in the case. Then, autoimmune hemolytic anemia. In autoimmune hemolytic anemia, only RBCs are affected. Other blood cells like the white blood cells and platelets are not affected. But in this case, the white blood cells as well as platelets are decreased. Erythropoietin deficiency is very unlikely as nothing is mentioned regarding kidney dysfunction. So we're only left with paroxysmal nocturnal hemoglobinuria. Paroxysmal nocturnal hemoglobinuria is a hematopoietic stem cell disorder in which the cells lack protection against complement system. It is usually suspected in a patient presenting with intravascular hemolytic anemia, pancytopenia, and reticulocytosis. Flow cytometry test confirms the diagnosis. Thank you.